the ability to see a patient in their circumstances is probably the most important characteristic for a primary care provider and a pain management provider, because you can be really good with your knowledge base, but if you can't relate to people, they're not going to like you. And if they don't like you, they don't stay. And this is both a mission and a business. So it just you really do want people to like you.
No, yeah, 100%. That's honestly, that's why I like going to convenient care and stuff. I
Right.
I can't stand doing stuff like that because it's just they aren't helpful. They don't actually care about what's going on. They just get you in and out, and it's like you still don't get your problem fixed.
Well, there's
So
no continuity of care. That's what the
yeah.
issue is.
Exactly.
All right. So for everyone that doesn't know, this is Dr. Mike. How long have you been doing TikTok?
I've only been doing TikTok a little more, maybe 2 years.
Okay, I went whenever I was going through your videos, I went all the way back to the beginning and I couldn't remember, but it was like it's it's crazy whenever you go back to like the very first things
Right.
that people do because I swear it you see the shift whenever people make their content because no one goes in almost like making the content that they actually end up making.
Exactly. I mean, it's funny that you said that because when I first started doing this, I wanted to do medical humor,
Hmm.
and I fell like down a rabbit hole in the controlled med thing. I created a video, and I thought it was going to be like the first video of maybe five or six that I was going to make, and not knowing that this community even existed. I was just going to give a few, some of my advice, because of the fact that I dealt with it. I didn't have a clue about all the unmet need.
Oh yeah, it's TikTok is a different world too whenever it comes to this stuff because if you go on YouTube, the recovery community on YouTube isn't very strong. The Facebook groups, it's very separated. TikTok is the one place where
Disjointed.
it's like everybody's in there, but it's also very radicalized. Like so many people go crazy on here. It's hard to differentiate the bullshit from the good shit. I
So,
think
what was one of your first videos going back that really, like, how did you get people talking and chatting?
I think that the first video that actually really started the conversation is I had the audacity, and now mind you, I'm not part of the chronic pain community at this moment, but I had the audacity to introduce the concept that you're more than your diagnosis. That your diagnoses don't define you, and that there are a lot of needs that need to be met. That's fine, but you are not degenerative disc disease. You are not chronic regional pain syndrome. You are a wonderful person invited in the Lord's eyes, and you're just more. And when you're in chronic pain and your needs are not being met, though, this is one of the reasons why I'm so passionate about what I do. When your needs aren't being met, it's really hard to see more.
what brought you into the medical field? Like, what got you started and everything?
I
Just,
promised I was going to shorten this answer. Let me
that's
say
okay.
it to you this way. When Obamacare was passed, I was an emergency room nurse in Siler City, North Carolina, at an emergency access hospital that had 10 inpatient beds. And it the Lord said to me, "You could be doing more." And so he told me to apply. The funny thing is, I didn't know a single thing really about being an NP when I first applied. All I knew to a certain degree is he said apply. And I generally, even though it's often kicking and screaming, when the Lord tells me to do something, I do it. And so, yeah, I applied. I really thought it was going to be one of those things where I was just kind of witnessing to the people during the process of applying. I never thought they'd be crazy enough to let me in.
Now, what did your wife think about you applying? Was she
Oh, she
nervous?
needed me to apply because of my back issues. She knew that I could not go the distance. I could not have a retire at the age of 65 or 70 as a bedside nurse and still be a functional human being. So she really wanted me to do something different. And this is where kind of how both the Lord gives us what we need. Sometimes, most of the time, not necessarily what we want.
Sure.
It's a
Now,
blessing in disguise.
Yeah,
yeah.
absolutely. It absolutely is everything I ever wanted now. But it was not. I didn't set out on this journey with the expectation that this was going to be all that it was going to be. So.
Now, a lot of your stuff is very spiritual based too. You're obviously spiritual, at least whenever it comes to the content you make. Have you always been that way, or has it kind of grown as you've been in the medical field?
I think that, obviously we've all had pivotal moments. And so I'll say that. I won't say that I've always been this way. As a matter of fact, I didn't even get saved until I was 38. So I knew about Jesus all my life. But, as far as actually saying, no, okay, whatever you want, that's going to matter to me more than what I want. That's a relatively new occurrence, less than 20 years. And as far as it relates to my practice, that's, as obviously it's a weird balancing act every single day, because on one hand, you have to understand science. You cannot, it's not like I just sit there, well, when the Lord tells me to do something, I'm going to do it. So there's got to be that complete, core knowledge that you have. But at the end of the day, your core knowledge doesn't help you be as good of a provider as realizing that these people have core intrinsic value to you. That's what makes you a good provider. It's what keeps you from making lazy decisions because you're more interested in your algorithm than you are the problems that they seem to be having today. Today they're having a bad day. There's more going on.
I feel like you really empathize with people and you really put yourself in their shoes. So it's like you take on their pain.
Oh, I do. And to be honest with you, that's been the hardest part about being on TikTok.
I bet.
I was a complete, burnout from empathy.
Right.
Because I know right now there's a lot of barriers like right now because people can't direct message me. But I was getting 40 or messages that and each one of them, the stories.
I'm sure.
I thought I knew some stories before I got on TikTok. I didn't know stories.
Yep.
Wow.
I did not understand the truth of a lot of people's reality until this became my thing.
It's weird because you get all those and people really pour their heart out. Like, I mean, Marie and I help a lot of people with their recoveries and sobriety and everything like that. And just you go from not knowing someone at all to knowing their deepest, darkest secrets within the span of like a couple of days. And it's a very
nobody's journey is a short story.
Oh yeah.
And how do you differentiate? Like, okay, you're empathizing with someone, but how do you not give medical advice in the same direction?
Thank you for saying that because I didn't give my disclaimer. Remember, if you think you hear any advice here, remember it's only me putting myself in your shoes.
Right.
But the way you keep from giving because you focus on the conversation. The number one thing that I try to help them do is ask better questions. I'm not going to tell you that this is a 4 Percocet per day plan, or this person is not going to be happy on anything less than MS Contin with a little bit of Dilaudid. But there's nothing about that that I would even presume. Fortunately, there's a certain degree of it where the insanity or the inaneness of even thinking that I have enough information to give that kind of advice, kind of prevents it in the first place. But no matter what, you're always careful because people interpret things as advice.
Right.
They feel like you're giving them advice, whether you're actually doing it or not. So that's why every video has that disclaimer.
Yep.
I love that because it's true. It's like you need to give advice, but at the same time, it's like you don't know how that person's going to perceive what you're saying.
Yeah, Dr. Mike said no one should be on more than 1,200 milligrams of gabapentin. That's
right.
Not exactly what I said, but I generally don't like people being on more than that.
That's something that Marie and I deal with a lot. And obviously, we don't have schooling in the medical field, at least. And everybody wants to know, how should I start my subs or whatever, or start methadone and it's something that, I mean, no matter how many times you say, speak to your doctor, this is what people in the similar situations have dealt with, blah, blah, blah. They still people still crave for an answer because they're struggling. They're in hell. So they want to fix it.
Right.
But yeah, it's a hard tightrope to walk on, I guess.
It is, and and the thing about it is there's also there's the intrinsic knowledge that the DEA is watching everything that you do,
Right.
and they're looking for you to do something that sounds like you're practicing medicine, uh, that way. They're looking for that, and so it to a certain degree, it has been helpful also because when I make some of the statements that irritates the community, some of the rules that just quite frankly have to exist,
Right.
or the reality of the complexity of prescribing. It is good that the DEA sees me saying that too.
Now, have you ever had somebody like say like, "Oh, I'm going to call up the medical board on you," or
Oh, it
because it's
happens.
weird.
Oh,
I've
it
had that
happens.
happen in a video where my doctor was talking about the Burmese method, and
Yeah.
somebody was like, "I want to know the name of your doctor so I can get him fired." Like, and I'm
Right.
like, "Why?"
Yeah. First of all, why would I give you that information? Second of
Right?
all, you
People
putz.
can be weird.
No, but I think it's the funny thing that the number one reason why I my name called to the board, and it happens about twice a year, is because of my use of the word Dr. Mike, because I'm a doctorate prepared nurse practitioner, and I get a call from my board, the board of nursing, because in North Carolina you're dual licensed with the medical board and with the nursing board, and twice a year they call me and let me know. I just want you to know you've had this complaint, and I'm required to call you to let you know that you've had your complaint. I'm also required to tell you that you're allowed to call yourself Dr. Mike. So, and I've had, people are petty. Yeah, I don't think
Right.
there's probably nobody that has practiced 10 years that hasn't had the medical board called at least once.
That's crazy.
It
And
is.
actually, Marie and I were just talking about this too, because we were trying to figure out the Dr. Mike thing. Because we've gone through all your stuff. You talk about the nursing and everything a lot, but we weren't even sure about that.
Yeah, I was missing
There
that
are
little
several
nugget
videos, but
right
I've made
there.
over 1,000, so I understand why you might have missed
Oh yeah, yeah. Well, there was a lot to go through, which is
it.
awesome though, because it's I see some like doctors, nurse practitioners, whatever, get on here and they'll make like 5 videos about some random topic, and
Right,
so many people have like a million questions, and they won't ever respond in comments. They won't do follow up videos. They won't do
right.
anything. You
They
are
just want to bless you with their great smartness.
right, and you're actually getting on here and getting information out there and trying to help the community instead of just leaving people hanging and struggling.
I
You get a
love
lot of
what I
engagement
do.
on your videos, a lot of
Mhm.
engagement. So that
Mhm.
means that people hear your message, and that's important.
And it's also humbling.
Right.
When I first began this, I had never heard the term unicorn doc. I'd never heard a lot of the things that I know now, and it all made me feel like weird when they first started calling me that kind of stuff. Because I mean, um, I had thought I had thought that I was a lot more mainstream than I ended up being when the truth finally came out.
How would you try and encourage someone who is fresh into recovery to
Uh-huh.
look at their spiritual side of things? I was trying to figure out how I wanted to ask that. I
No, no,
have,
I got what you're doing there. I because I
yeah,
can go with I can because all right, but I have to tell you a joke first. When I first accepted the call to preach, this is now about the same amount of time, maybe 11, 12 years instead of 10, right? Um, one of my first places I preached at was a AA meeting, and my sermon was he's more than the God of your understanding. So I wasn't invited back. But now I understand. Now I know how to introduce the concept of the fact that you're not alone in this universe in a way that is not, that kind of jives a little more with NAAA, and because the most important thing that I would say for someone that's new to sobriety is you've already submitted yourself to this chemical for all this time. It's not you're simply moving. You're changing teams. You're still going to be subservient to something, but now you're going to be subservient to something that's higher than you. And the problem is that you were not high enough. Okay, you yourself is. The problem is that inherently You don't have all the answers enough within you to actually manage all this. So you got to go higher, and you got to kick it up. You got to kick it upstairs. And whatever that means for you, I got my own views on this. And by the way, if you have a moment, I'd be happy to share. No, but regardless, you have already been doing this process. You kicked it up higher to a substance, and that substance led you astray. And now you're kicking up higher to something that's actually going to lead you away from it.
So do you have patients that you just know that they're not doing the right thing based off of their toxicology reports?
Absolutely. Absolutely. And one of the things, go ahead.
What happens in that situation? Because I was kind of one of those patients. It started off as pain management, and
you have lots of really difficult conversations. One of the ways that I say it, the way that I have figured out how to say it that is the least judgmental that I can kind of come up with, is that you have a higher affinity for the medicine than you do your pain. The problem is that you have two problems. You have chronic pain, which is real, and you have substance use disorder, which is at this moment is even more real. And I usually point to their lack of control. At the end of the day, because remember, I actually have three categories. Remember that I have the therapeutic use, and those are the people who can follow the rules, and they'll always be, they're rarely going to ask you for an increase. They found a regimen that works, and that's all there is to it. The substance use disorder, which is the entire opposite end of the spectrum, but then there's this thing in the middle called chemical coping. And chemical coping are people who are kind of always sliding towards therapeutic use and also towards substance use disorder. Their life is inherently more productive if you can meet them where they are, but they're the most difficult to manage because, like what you're mentioning, when they get an abnormal drug screen, that's why it's not like one and done at my clinic. I have to try and figure out, because and this is how I teach new providers. I said, there's a question you have to ask yourself, and you have to constantly repeat it. Are they safer in your care than out of it? See, people that give you an abnormal drug screen, they may actually still be safer in your care. Okay. Yep. You may, if you can come up with a plan, tighter rules and things like that, extra visits, extra look-ins on their drug screens and stuff like that.
Accountability.
Right. Because if you leave them to their own devices, but you got to see, but that's the question. You're always asking yourself that question, because sometimes that real substance use disorder patient, no matter what you do, they can't ever pull the following the most basic of rules together. And then, then they end up being really more medication-assisted treatment patient. But I don't like how quick that question is answered by most providers. I think that we could be a lot more effectively engaged if it wasn't, well, you broke the rules, you're done.
And I wonder how many people just end up like making those mistakes just because they feel like they can't talk to their doctor, because everyone's afraid to say whatever to their doctor, and then boom, you lose your medication.
But another reason why they make mistakes is they begin to lose respect for the danger of the medicine itself. Yeah. That's another reason. And that's where I'm not arrogant when I say it. That is my job. I have to be those guardrails, because you're not going to be.
Yeah, no, I like that a lot.
No, you're looking at it from every different angle and direction. When you're looking at a patient, you're seeing it every which way.
Right. I mean, because what does a successful pain plan do? A successful pain plan puts life in the middle of pain. Okay? It doesn't actually resolve the pain. It increases life in the middle of pain. And so, the thing about it is, that's why I've come on. You've seen me do some videos where I said, well, that pain plan sucks. You're getting 3 tramadol a day, and you're being patted on the head and telling you just suck it up, and that's the best you're going to get, and you're not having a real conversation. Well, if those 3 tramadol a day are not actually letting that person go out and get a job, your plan sucks. Okay, right. If that 3 tramadol a day, it allows them to sit on their ass a little more comfortably, that is not a pain plan.
This issue comes up a whole lot. I mean, there are so many people, whenever they go in and they get their pain plan, they can't get more of a accurate care or something that actually improves their quality of life because either their doctor isn't willing to tussle with the DEA or the pharmacy or whatever. And it's sent a lot of people either to MAT, which has its benefits.
Maybe some inappropriately, maybe sent some people inappropriately to MAT.
I agree.
Or they end up going to the street because, okay, my doctor's not going to help me, but my neighbor will.
Right, exactly. One of the things Claudia said early on when I first met Claudia, that wasn't one of the things I ended up agreeing with, but I agree with it more the longer I go. And that's just, she said that one of the things when we were all prescribing, ridiculous amounts. And by the way, I don't agree with the 2016 guidelines, but I do. Two things can be true. The guidelines were completely stupid, and there was still a problem with the way we were prescribing opioids. Okay, two things can be true. But my point was, is she said when we were prescribing, we were creating a safe supply of opioids because of all the diversion. And I said I said at that time, and I still don't think it's my job to create a safe street supply. That's not in my wheelhouse. But I understand the logic.
As someone that struggles with chronic pain myself and in recovery, I get this thing like where if I really get hurt or something, like it takes me a lot to want to go to like the emergency room because I already know what they're going to say. But the thing is,
but they're not going to help you. 8 times out of 10, you're not even going to be helped. You're going to sit there for 8 hours.
A lot of these doctors don't understand that pain is a trigger.
It is. Come on, especially for this. Right, exactly. So in other words, I'm going to say. I think I'm going to say what you just said there. You're a substance use disorder patient, and you've been doing really good staying clean, and then all of a sudden life happens, and you have legitimate pain. And maybe if you could actually have that pain met, you wouldn't actually lapse because you'd be under guidance. It would be for a defined period of time. Because I have given short-term opioids for substance use disorder patients because they broke an ankle and stuff like that.
Right.
But again,
and a lot of these doctors will not do that. They don't want to hear you, and that's the problem.
They don't. That's because they've already marginalized you, and I understand that. And I did not appreciate how marginalized this community was. The good news is I had empathy before I ever came on TikTok. But I had no concept that I was different.
So what do you do for that person that, they are a little bit riskier, but you need to prescribe them pain medication? Do you do like a follow-up afterwards? Like, let's say you give them 2 weeks of perks or whatever. All right, you've been taking them for 2 weeks, and then you follow up and say, hey, how are things going? Were you taking them appropriately?
Exactly. All that and more. The first thing is, if someone is a high-risk patient, they do not sign a contract with me without me knowing that that's my opinion. Okay? And it's not judgment. I just simply say, it's going to take a lot for me to keep you between the lines. I call it the mayonnaise and the mustard. It's a driving analogy. You really want it when you're driving, you want to stay between the mayonnaise and the mustard. The guacamole is going to get you into hell every time. See what I'm saying there? Okay? And so, but they know, one of the things I never, ever want a patient to experience is hurt because I was not upright about who I was to begin with. Because I can be an ass when it comes to this topic, okay? If you're not, listen, if I have to have a conversation with you because you're not following the rules, those are not pleasant conversations. They're loving conversation, but they're not pleasant. And so, yeah, to your point, to answer your question, I got a little bit ADD rabbit trailed on that. To answer your question, so the first, you absolutely, if someone that's high risk stays on every 2 weeks for a while, I actually might get 2 urine drug screens that are consistent before I might release them to monthly. Because we're gonna assume for this illustration that it's C2s we're talking about, which I see every 4 weeks. Okay, so and remember, for me, what's the point? The point is I'm actually trying to get someone into primary care. Okay, I'm actually trying to get them to actually engage in the rest of their care, because that's why I do both primary care and pain management. If I can get their primary care need met, then all of a sudden we can start talking about that A1C at 15.
How do you create something that can make that more like mainstream? Because that, I feel like, is almost...
You mean like a plan, like a program that you could institute, something that you could franchise and spread? There would have to be a lot of DEA changes.
A safety
Right.
plan. Like I
Right.
call that a safety plan where
Exactly.
you have it all documented, signed.
Right.
That's
Well, I mean, and that the safety plan within the pain clinic exists, but the problem is, I think what you're kind of going more towards is how do we duplicate Dr. Mike elsewhere? I
Yep.
think you're
right.
really kind of going after that. And the reality is, first of all, the ones that are like me already are. Okay,
Right.
you know, I mean, you don't have to teach what the empathy that I have is not
Right.
something somebody taught me. It can be taught, but it's usually to a lesser degree of reception. You know what I'm saying? Yeah, it's like me learning. It's like me learning how to play baseball. I'll never go pro. Okay, I might eventually learn how to be competent in a position or something like that. I might even be able to get off the bench once in a while. But other than that, I probably won't go pro.
Sure.
But as it relates to just without a change in the oppressiveness of the biggest oppressiveness right now is how they monitor your actual prescribing patterns and how they use pharmacy claims to start lumping you into categories before they've ever asked you one question, before they've ever looked at one of your charts.
Is that
just,
NARC score? Is that considered NARC score? Is that what you're talking about?
No, the NARC score is a whole different thing. The NARC score is something they led us to believe would help keep patients safe, and it's just not. That doesn't prove to
Right.
be true. The NARC score, the reason why we use NARC scores is, first of all, to be seen not using them will bite us in the ass. Again, back to DEA, stupid things you have to do just because it's the government. But I was an adapter when we first had NARC scores because I would use that information. And I thought that by using the information to have conversations, I was keeping people safe. When in reality, I was already having all those conversations. When someone's on a combination of benzodiazepines and opioids, which I still think is appropriate for a lot of patients, we were already doing those things, and all the NARC score did, because they don't even line up. The amount of how flawed the NARC score really is just, it's inane. I reviewed them now. They affect my clinical decision 0 points.
I think whenever it comes to the NARC score and literally just being like flagged as a substance user, people feel defeated once like that
Right.
really gets serious. That's why they won't go to the emergency room when they're hurt or whatever. They will go to their neighbor, and who knows what they're going to get, because
Who knows what they're going to get? Right.
Yeah, it's just you feel like whenever you go in, even if you are just a pain patient and you go into the ER and you've been taking, I don't know, Oxy for 10 years, oh, you're a substance user, you're horrible, get out of here.
That's just it. They don't have two categories. Everybody is in the same. Heaven forbid you've been on meds for more than 30 days. You're in that category regardless.
Now, what happens, because I get this a lot, where medication shortages can't find the medication within a 50-mile radius. Doesn't that increase the NARC score?
I don't know. I actually don't know. I think I've considered the score so irrelevant for so long that I've not followed that trend. I can see it. I can see what you're saying. I mean, I can see,
because I think I've heard that if the doctor's not within a 50-mile radius, you're flagged.
Yeah, okay. Yeah, if you're traveling further than 50, that I do know increase your NARC score. I'm sorry. I thought you meant the availability of the medicine.
I meant both, actually. I meant both.
Yeah. Oh, okay. I have not. I know that if you drive that far, and quite frankly, most pharmacists are no longer even. They're not even helping you in those regards. If you're the one that's 50 miles away, they're just telling you don't even start your drive. You end up having to just choose a different medicine or something like that. It's terrible right now. This morning I was thinking about, because I knew that we were going to hit on ketamine, and we were going to hit on Lord help me, kratom today. And all I can say about pain management right now, it's the wild, wild west. I mean, it really is, both good and bad to a certain degree. And what I mean by that is if you can find those marshals in the right town, justice can be done. But finding that marshal is not easy. And where there's no marshal, there's no rules, and it's just pandemonium. It's just terrible. I make some of my wacky advice because of because we live in the Wild West.
Do you think things are improving in any way because of all the DEA guidelines?
Only by attitude. I do see some improvement in prescriber attitude. And to be honest with you, that's causing its own fear for me, because I'm worried that they're all of a sudden going to start prescribing, and it's going to be prescribed what? I think that all of the measures they did to make Suboxone more accessible does help some folks, but
Sure.
it does nothing to address the core issue. Because to me, all you're really doing, can we agree that substance use disorder clinics historically have been predatory towards the substance use patient? Meaning that we don't file insurance. It's going to cost you this much to get clean, and so then you had your whole caste system of the people who could scrape it together and the people who couldn't, and and they just they wrote to anybody that had they were actually more of a pill mill than even the legendary Florida pill mills. The Suboxone is to be traditionally used for pain management, as the modality of pain management when you're not a substance use disorder patient, is awfully, it's basically cookie cutter, and it's just not. It doesn't embrace the reality of the fact that we all have different pain journeys. We all have different needs to be functional here and functional there, and and we all have different. Suboxone is not the best proprioceptive. It's really good when you have two problems, but it's not really good if you only have one. It's not that it's kind of like Wellbutrin. Wellbutrin has like 20 different FDA indications, and it's not good at any of them. Sometimes it really fits the bill on somebody, and it really hits home, but it's not really good at any of its indications. Suboxone for pain management, kind of the same.
What do you think about methadone, like being more accessible to people to be able to get methadone wafers prescribed at home?
The reason why methadone has worked in the past is because of that really close representation. Methadone is, honestly, has one of the highest risks of overdose. For a person who is known to abuse a substance, I'm glad that we're getting to the point that we can find where we can select that patient that is the most clinically appropriate to do that. Okay, we're kind of getting to almost the therapeutic use patient of a substance use disorder. So I mean, we're getting to so there are a segment who are so motivated, they're gonna follow the rules to the T. They would never think about taking an extra, none of that. And I'm glad that that's available. I think to a certain degree, it's a little disingenuous to think that that's going to be, the mainstream way that this is, because the reason why it's worked in the past is because of the direct observation, and we're only giving you so much at a time so you don't kill yourself. And I don't want to lose that. I think I want to have that, the home stuff available for that right patient, but I think it's 15%, maybe.
Now, do you think that during COVID and stuff, it changed like a lot of the rules
it became necessity, right?
Right.
We changed the rules because but that doesn't mean, okay, telehealth for all the, remember how everything became telehealth? Yeah. Telehealth is not a great way to give care. It is not.
I agree.
Listen, it's a great way to initiate care. It's a great way to handle a lot of care. I think a lot of insurance companies have stopped covering telehealth, and I think that's just as wrong. But there's a lot of care that physically cannot be delivered that way. And so we had to do some things because of the reality of how many people were dying. And, that was a great then plan. I say about pain plan, that almost all pain plans are today plans. Well, that was a great today plan, but I don't know that it's sustainable long term.
What is your suggestion to that pain patient, not said patient, but just pain patient who had done everything right and all of a sudden their doctor cut them off or switched them to subs, and they're like, you're going to take these subs now, but it's not helping with the pain? What options do they have?
You need a new doctor. I mean, honestly, you need a new doctor. And it's you're about to embark on a long and lonely journey. do not state this thinking it's not because I don't understand the reality of the situation. But even understanding the reality of the situation, do you want to have the person who cares for you the most to be someone who doesn't actually have your best interest in mind? You need a new doc. You got to.
And you know what else is sad? It affects people, even people that are in pain, but it affects your mental health.
Sure.
It affects their mental health throughout that whole journey of trying to find a doctor to validate them.
Right. Today we were studying 2 Samuel chapter 13. We're talking about Tamar. Tamar was one of David's daughters, and she ends up getting raped by Amnon. And the point is, the reason why I'm saying this, for 2 years, she has to basically be, she is in one of the houses. Basically, she's completely disreputed, for something that had nothing to do with her. And that's what I link that back to what we're talking about here. I don't think that that you should have to suffer for something you didn't do.
Do you think there, along with the like follow-up visits, whenever it comes to your pain plan and everything, if a said person does end up getting those pain pills for surgery or whatever, let's say, do you think there would be something beneficial beforehand? Like you watch this video, take this class about pain medications, and it teaches you the dangers. Do you think that would actually stay in the forefront, or would that be useless?
I'm not convinced that it would be especially helpful. And the main reason why and that's really a good question, though. I might have to, I really might have to think about that longer. But thank you for that. But I think that people who become problematic with the substance knew, at least intellectually, what was the potential downfalls of it, and they felt that they were stronger than the substance. They felt incorrectly that they were stronger than the substance, and there's no haterade. I've gotten myself into a lot of them. It's like when your mouth writes a check your body can't cash. I think sometimes we think we can handle something that we just can't, and I don't think that it's a knowledge debt. I don't think that most people think pain meds are harmless. I don't think that most people think alcohol is harmless. I think most people think that the ones that are going to get into trouble are the ones that don't respect the fact that they're not harmless.
Yeah, and I ran into that issue. Like whenever my problem started, I had a really bad back injury and went to my doctor, and I was raised to trust like whatever the doctor says. The doctor knows what they're doing, no questions asked. Right. And it was back in the day before I had ever been like introduced to anything with
opiates. Everybody had Vicodin in their medicine cabinet because it was just something you kept around to break glass in case of emergency.
It was just another medication. And so I ended up taking it as prescribed for 3 months, no issues. And then I figured out what it was like because I told my doctor, hey, I don't think I need this anymore. And so it was just discontinued, no taper, no nothing.
Right.
And I figured out what withdrawal was like. And that led into, of course, one of my coworkers had some and was like, oh, take this. And it was a higher dose, and it led into a whole thing.
Right. But, and you spiraled. Right. And no haterade. Look, I mean, you got to understand, there is not a single person on this earth that hasn't through lack of foresight, spiraled into a situation that was completely beyond their means. Quite frankly, that's why we have a Jesus, because if we could manage it all ourselves, there'd be no need.
Do you want to talk about Kratom? I'm really interested about that.
I was about to ask the same. That's funny.
So the way it was worded to me about like how Mike had brought up is, why do you recommend Kratom? First of all, let me say, I actually my current standing is that I'm not necessarily recommending it, but I am telling you that if I was in your shoes and I did not have access to opioids, I'd be daggum if I wouldn't try it. Okay, and I have tried it now because I wanted to know how it. I wanted to know, what it did for me. Did it actually, was there anything to this whole Kratom thing? And so, living in the wild, wild west, okay? If I was living in the wild, wild west, in this case where, water was not easily available, and you got to drink them, you have to drink what's available. And so if you need opioids, if you need pain management, if no one is talking to you and you've never tried it, then I would do what I did, and that is that but just keep in mind, just like you have to respect that opioid, you've really got to respect kratom too. Kratom is not harmless either. Kratom is a delightful substance, meaning a delightful supplement, and it can be used. Basically for me, I got a positive pain response from it. If I needed to manage my pain with kratom alone, I would probably be able to. That doesn't
Now,
not the same as
where
an endorsement.
where do you find a reputable source? Because we don't want to just go to a gas station for kratom.
Yeah, I think that you're better. I mean, for most parts, you're better off online. Most parts, you're better off looking in the kratom community here on TikTok. Most people, know reputable stores. I don't think you should do gas station kratom smoke. I haven't tried. When I decided to try kratom, one of the kratom creators reached out to me and gave me some stuff completely gratis, so that in the interest of me being able to say one or two things about it. The most important thing, if I was going to be in your shoes, I would just simply say, start with two. Don't start with a dose that is higher than 2 grams if you've never been on it before, ever. And then go up a half a gram at a time until you find something. And here's what you probably need to be thinking about if you're going to be doing anything kratom. If I was in your shoes, and that is delightfully subtherapeutic. I want something to move the pain needle. Not necessarily, I'm not trying to get to zero. Not.
Sure.
I'm trying to get to functional. And because it is not a psychedelic, it didn't give me any of that stuff, but there are a little bit of CNS effects, okay? You can get a little bit of dizziness. You can get a little bit, depending on what strain you're using. And I'm not going to get into that because, this is exactly why I'm asking you to be cautious. And I wouldn't recommend that people who are using kratom to manage your pain, I encourage you to keep looking for a prescriber that will prescribe you opioids, because it is a plan that sucks. Okay, it is a plan that's better than it's a whole lot better than nothing, but it's a plan that sucks. It's a plan that basically we're trying to use a compound to get something to a receptor to activate that is a whole lot less efficient than the actual things that we have that make that thing activate.
Right. Do you think it's, and again, only go into what you feel comfortable with, but do you think it's sustainable as a long-term pain management?
Yeah, I actually, for the right patient, and here's the thing. Again, don't operate in a bubble. Your doctor needs to know you're taking kratom too. And that's, especially if they're refusing to give you anything else, they need to know that you're using kratom, because it matters for your COPD patient, your heart failure patient, anybody where they get just a little bit of respiratory depression, it can tilt their whole teeter totter. But yes, though, with all of those caveats, could I manage myself long term with kratom? I probably could. Yes, I'm fortunate. I don't need pain medicine every day. I need it actually very infrequently. I'm able to use a lot of physical modalities, but that's just my story. I don't,
Sure.
I don't live that. That's not somebody. I don't live somebody else's reality.
This is something that I've experienced, having doctors say like, "Oh, you need a psychiatrist. You need to see a psychiatrist because your pain issues or whatever." Like, even though they're on paper that there's issues, but like, do you push people?
Absolutely. I mean, why do they need what's psychiatry going to actually offer?
Right.
They're not going to offer anything. And I don't like that referral very much at all. First of all, most of the time when we're referring to psychiatry, what they really need is counseling, and psychiatrists don't counsel. They only prescribe medicines. You're kicking the can down the road. You're trying to say, I can't help you, without saying, I can't help you. If you can't help them, have the cojones to just say, this is not something I'm able to help you with. Listen, sometimes the most therapeutic answer I can give is no, because at least it's clear, it's concise, and the way I say no, it's not hateful.
Marie, do you feel like that's just because of the SUD patient thing? They literally think you can't handle taking anything yourself, or you can't handle what's going on around you, so I've
had both experiences. Like,
exactly.
Yeah, I've had experiences where like my knee popped out of the socket one time and it was excruciating pain and I really didn't want to go to the ER, but I did. They're like, take ibuprofen. Hello, if I took that at home and it didn't help. Like I'm literally
Right,
here telling you, like I'm super triggered right now.
right,
And oh, go see a specialty doctor. You can't even get in to see them for months.
right,
They leave you to your own vices. That's
right.
the issue.
And that could, that takes us kind of full circle back to where we said earlier. Are they safer? Most. That's why I want, that's why I want more primary care to write for pain management because that's um, at the end of the day, are they safer in your care or out of it? And most of people, even substance use disorder patients are safer cared for
Oh,
I
rather than
agree.
rather than left to their own devices.
before we get into ketamine, I just thought of something. How do you feel about like full on safe supply? Because we've had Dr. Orez on, and he talked about like a all in one safe supply. You get your medication, you have therapists on hand, whatever. Do you feel like a safe supply situation could actually be beneficial for the substance use community, or no?
I don't disagree. The problem is the problem I have with that is the same problem I have with the substance use disorder community right now. You cannot go to a Suboxone clinic and know what you're going to get right now. Okay, meaning this, that there's so much difference between one clinic to the next, and so much difference between personal accountability and responsibility. And I feel like the safe supply idea just takes that and just compounds it to a higher level. And because the only way that works is if we're all using the same playbook, or at least the same cookbook. And then we're not all coming up with our own various, and it can't be profit driven. Insurance would have to pay for it. You see what I'm saying? It can't be this is a $500 a month venture for you to to stay sober. Yeah, can you tell I'm a little irritated at folks that are trying to stay sober and they're just getting raked over the coals by the cost?
Oh yeah, that's 100% cost, transportation, all types of stuff.
Right.
Right. What do you feel about medical marijuana? Because I was in the Subox when I was on Suboxone, I got penalized from a monthly patient to a biweekly patient because of my medical marijuana card.
Okay.
Never filled a urine screen.
Yeah, I am absolutely on board with medical marijuana. I find it to be one of the best neuropathic agents for the people that it works for. Better than gabapentin, better than Lyrica, better than amitriptyline. Anything that we would, and the list goes on. Cymbalta, and again, who's it for though? It's for the responders. Not everybody is a good THC responder. But my point being is, I know I haven't for at least 3 years. I have allowed my patients to use THC. I can't give medical marijuana in North Carolina, but if it shows up in the urine, it's not a infraction. But even for my folks, the thing about it is when I let them use THC, I prescribe less opioids. And THC is less respiratory.
That
So
makes
it's
sense.
it's matter of fact for me. I get to prescribe less controlled meds if they're allowed to adapt. Now, what I do, and I got someone on my list right now. What I do is when they're blowing the top of the charts off of the THC, we still have a
Yeah.
conversation about you still need. I need you connected to this world. It's not a panacea for all THC. Come on, but um you especially remember it's one of my other themes. A pill is not a plant. Part of the reason why we're in this mess on all sides, substance use disorder, therapeutic, doctors, patients, is somewhere in the past we got this stupid idea that a pill was a plant, and in reality, nobody's pain is so non-complicated that the pill is the entire plant.
You mentioned it earlier with like using benzos and pain medications at the same time. How much of that narrative is that abstinence narrative? Like if you're using something else, you're going to be led towards whatever.
I don't buy into it very much, and let me explain what I mean. I think a person with an addictive brain wants to be addicted to something. Okay, so in other words, you're going if I take this from you, You'll find something else that, like most former substance use disorders are still addicted to caffeine, or they're still addicted to nicotine. Okay, I'm just saying, it's or shopping or something, but it's gonna be something.
Yep.
Okay, it's gonna be something. Okay,
Right.
I don't buy into the dialogue that something is an entry to something else. I think that the addicted brain wants to be addicted to something.
Do you believe in therapy, like therapy along with pain management?
Sure, absolutely. I believe
Therapy-
in most instances.
Therapies helped me tremendously to get those tools that I didn't have before.
Right, because a lot of times when you were in your substance use, you were not actually dealing with you. And,
Right.
and you're not able, and to a certain degree, you didn't understand all the reasons why you do some of the things that you do. You knew you were making bad choices. You tried not to make those bad choices. You still made them, but you had the concept of why you kept repeating the same cycle. So yes, therapy is absolutely, that's why I say that, chronic pain and mental health are kind of two sides, two things that have to be addressed concurrently. And again, going back to the pill not being a plan, I'm not saying every pain patient needs to be an antidepressant. That's not what I'm saying. But every pain patient has issues with their emotions.
And even using, just getting off subs and everything, it was like your emotions go freaking crazy whenever you're coming off all that.
You're not prepared. And you can be easily not prepared for that. Quite frankly, the obese patient has to do it when they come off comes off Ozempic. That's why Ozempic often ends up being in perpetuity medicine.
What do you think about this whole gabapentin kind of getting thrown out like Skittles now? Because since the pain pills aren't as prevalent or as easy to prescribe, it's just, oh, here, have some Gabs.
Well, let me tee up our next topic by saying this: ketamine is the next gabapentin. Okay, that's all right. So that's my worry there. The gabapentin, and the way that it's prescribed by a lot of providers is the reason why it's the reason why it's hated. Gabapentin is actually a really cool drug for that right patient, and I still prescribe it a lot as an adjunct. I just don't tell somebody, I don't give somebody gabapentin and say this is going to replace your Percocet. No, it's not. It's like saying it's like giving you a teddy bear saying it'll replace your sibling. You're just telling me things that my brain knows are not true.
Right.
Part of the whole problem with trust in the community is we're telling blatant lies as if they're the truth.
Now, a lot of people do not like gabapentin. Now, I was prescribed gabapentin as well at a very high dose. I felt like it really didn't do anything for me, to be honest with you. What do you recommend? Like, I know it's all individualized, but like,
sure. I'll give you my spiel on that. Absolutely.
A lot of comments.
Let me say this: if gabapentin, to me, by personal use, meaning when I use it with my patients, if I haven't seen the needle move by the time I get to 1,200 milligrams, I don't go any higher. I feel like if you're going to be a responder to gabapentin, you're going to be a responder at lower doses, and then we might consider higher doses because you're a responder or because side effects are low enough.
Yep.
And again, it all goes back to and. I would never. The problem with gabapentin is the or med. This is take this or else, and that's the problem with it. Nobody wants to be. This is going to be everything you need for your pain. No, that's just bullcrap. But you're doing pretty good on your pain medicine. I think you could be doing a little bit more. I'd like to add 600 milligrams of gabapentin at bedtime, and we'll know within the first month if we're seeing any benefit. And if we're not seeing any benefit, fine, but at least we know we tried. That goes back to a pill is not a plan. Now you're starting to come up with the plan. So you got this main stem, then you got this adjunct. And by the way, Mama, see you doing your stretches and your hot tub therapy and all that stuff. I want to know about that, okay? How much are you walking? See all these things. But when gabapentin becomes an and, it takes on an entirely different paradigm.
And it's just another one that the education that doctors are giving to their patients is just not there, because you can look up online all the side effects.
It's a lie. It's a lie. Yeah, the education that they're getting, because again, this goes back to Sometimes the most therapeutic answer is no. If you're giving gabapentin because you refuse to give anything else, you shouldn't write gabapentin. That's not the reason to prescribe that medicine. If you see somebody that has neuropathic pain and you've never tried gabapentin and you refuse to try gabapentin because you've heard about the bad, because you heard about all the side effects, you're also being, too narrow-minded too. Okay, it's just don't listen. Nobody in this window, right? Nobody needs in our window here needs to stay on a medicine that doesn't work.
Right.
People are saying in the comments about acute pain with gabapentin, like it should not be prescribed for post-surgery.
Not.
And it's happening though. It's happening
all the time.
A lot.
Right, all the time, and it's stupid because you're right. It's the same as low dose naltrexone as it relates to that. Okay. We'll talk about low dose naltrexone briefly then.
Yeah.
My point is, the reason why people believe that it works is just because it attaches to the same receptor. That has nothing to do with whether it produces a therapeutic effect or not. Just because it sits on it doesn't make it useful. And there's a lot of toilet references you can pull right into that one.
I actually am helping someone right now who messaged me a week ago, and that was exactly what happened. She had issues with alcohol and stuff like that, so it was a somewhat viable option there, but it was supposedly, according to the doctor, going to take away her pain. So
take away are my favorite words to hate.
Yep.
Period. In all of pain, one of the things I have never, ever, ever promised is that I'm going to take away your pain.
Yeah.
It's the biggest lie. It's the reason why the 2016 guidelines ended up being enacted, even as misguided as they were, because somebody had this crazy idea that we could take away pain, and that's not a reality.
I think there was a placebo effect at first, because the first day or two, it kind of helped and stuff like that. But then after that, it was things are slowly getting worse. And now she's miserable. And it's you also now can't take, you can't easily get opiates and stuff like that. So now you're kind of in a ditch until it wears off.
Well, no, right. You know what happened the first 2 days? The first 2 days is the receptor was glad to have something there.
Sure.
Okay?
Yeah.
It wasn't necessarily completely placebo. The receptor noticed that there was a difference, but it was like taking artificial sweetener. Eventually, the body goes, you know what? This crap is not sugar.
So how does the gabapentin lead into the ketamine side? How are they so similar whenever it comes to the way they're being used?
Go to a ketamine infusion center. Look at what they say that they can help you with ketamine. I mean, it's like 8, 9, 10 different things. And it's just come on in here, give us your cash, because it's not approved, it's not paid for by insurance. This is the other side of the wild, wild west. Okay, now you have people coming in here that are literally victimizing and already. I'm not saying ketamine cannot be useful for chronic pain. Let me roll back just a little bit.
Sure.
My problem is that there's no one taking the lead to do this the right way, and there's no one thinking okay. And now we're back to ketamine okay? There's no one thinking and so, again, the only ketamine that is an approved insurance product is Spravato, and that's the nasal ketamine used as a management of treatment-resistant depression. Everybody else are open. Now I caught your cough. Thanks. Okay. No, but everybody else is going with these freestanding ketamine infusion clinics, and they're like, come to us with your PTSD, come to us with your neuropathic pain, and there's no oversight, because it basically since everything is off label, there's no protocols, nobody is taking the lead, and I have grave concerns about an industry that is just popping up overnight. We should have had the same concerns over Suboxone.
If you go onto our YouTube channel, we just actually talked with NAD plus Detox. I don't know if you've seen them on here, Justin, but I feel like they are actually making a decent attempt to do the ketamine and they're doing NAD plus, and they do aftercare to some extent.
I mean, they sound like they're doing a fantastic job, and I'm not discounting anybody that's doing a great job with ketamine. I'm not saying nobody's doing a great job with ketamine. I'm saying we don't know who's doing a good job and who's not. Right. It is so, that's where the Wild West comes from. You don't know if you can trust that hombre over there or not. And I don't like where we're at as it relates to that. Also, I really don't like the idea that they're just calling out some of these particular mental health disorders that are not on label, like PTSD. I'm sorry, but the disassociation you get with ketamine could be very harmfully triggered. Could harmfully trigger a PTSD patient. And it's not that it will, it's that I don't know.
You have to know that patient and know the trauma that they've been through to know like when they're disassociating, what can get them back to feeling comfortable again to go throughout their day.
But going back to early Suboxone therapy, how much of a clinical workup did most of these people actually get? They really, their workup was their down payment for their therapy was their workup. And I'm worried that ketamine, because of the fact that, and I'm not all about regulation, but because that there's no rules. Whenever there's no rules, I worry.
Yeah, I know people like, for instance, Dr. Alfrey, his wife has CRPS. And she does the ketamine infusions, and he said it helps her tremendously. Each your own.
I can't discount it. Right. I'm not saying it doesn't work.
Yeah,
but I just what I want to know is how do I, what mechanisms are there in place to make sure that the person you're going to actually has a vested interest in your health and is going to do a good clinical workup before just deciding that you're a great ketamine patient? I'm sorry, but if you've got $200, you can be a ketamine patient. Whatever. I don't even know how much stuff costs. All I know is it's cash based, and if you have, I'm worried that when you don't have to worry about regulatory bodies. The reason why regulatory bodies exist, as much as we hate them, is because we found out what we do when we're all on our own, and when there is no accountability.
And so ketamine treatments are normally upwards of $10K, which is crazy for, any type of treatment, but that's how rehabs are and everything. And this has kind of been the norm for the substance use community for quite some time, is the sub clinics, the MAT clinics.
Exactly.
It's all the same way.
It is legal exploitation.
Yeah, completely agree. So what do you think, and I don't know how much you actually know about this, but how do you feel about stem cells whenever it comes to substance use disorder? We were just talking to someone who's autistic, and he was looking into stem cells because supposedly it can help. Is there are stem cells a way to fix the substance use disorder side? Because I just watched a video about all this.
I'm not convinced that is a true statement. The thing about it is, it's like protein-rich plasma. Protein-rich plasma has a lot of benefits. I don't think it has all the benefits that it's touted to have. And I feel the same way as it relates to stem cell. Stem cell, I think, for the autistic, I think that there's something there. As you see what I'm saying, I can see how cognition and things, but what is it hit? My question would be for the substance use disorder patient, what is that stem cell actually targeting in the body that produces the change that, and how do we know that it is, and where can you show me that there is this reaction or this connection happening? It's a great concept, but it's actually, I think it's more just throwing around the label that's actually meaningless in the manner in which we're using it today.
And I wondered about that, and I understood. So where they're coming from is they're saying that whenever you're taking all these pain pills and everything, you are creating those more neural pathways for your pain receptors.
Oh,
basically.
So they're talking about it heals them?
It's basically all that.
They're saying that it goes in and it soothes. It's a balm on all those extra receptors.
Yes.
Okay. Who knows? To be honest with you, I don't think that I mean, honestly, we are in the same realm as we are with a lot of supplements. Okay, well, this thing really works on your blood pressure and da 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 da. And some of them actually have an effect on those things, but it's so unpredictable. That's why they're supplements, not medicines.
Right. Yeah.
I don't think that I would. I would try ketamine before I tried. Let me just here. I'll put it in tiers for you.
That's
I would
fair.
go with ketamine first. I think there's actually a little more science there.
That's what I was saying. That's what I was telling him. I think that might help him.
Well, in stem cells, it's not new per
It's a
se,
reach.
but
It's a reach.
right. Yeah. Yeah. I don't
It
know.
is a reach,
I saw it.
and
That was crazy.
it's actually the way it's used. It's okay. What was my favorite term to hate? Oh, I used to hate the term gaslighting when I first became a creator because I'd never heard it really used in everyday conversation. Blah blah blah. And they were always in every single comment on my first videos were all about gaslighting to the point I got like, what? I get tired of hearing this. I'm just trying to give you some information here. Anyway,
Right.
I think stem cell has become my new gaslighting.
Where do you want to take your content? Like you're obviously starting to grow quite a bit, and I've seen you do like lives, and Marie mentioned it too. You're doing lives with the spiritual side of everything. Is there something specific you want to do with your content to spread kind of the overall message, or is it just you just enjoy making videos?
I have so much to say about a lot of health topics that are not necessarily chronic pain related. Remember that I'm a primary care provider first, and there are so many ways that people need to interact with their lives. I think the problem that the thing with chronic pain is it's keeping people from actually interacting with the rest of their lives, and that's why it takes such a. But I would rather sometimes just be able to really get into the brass tacks of this. There's more to you than your chronic pain too. But
Yeah.
so far it hasn't, that doesn't take off.
Did you have a last topic you wanted to talk about real quick?
No, I think y'all have done a really good job. First of all, this has been a blast. I just want to let you know I've had a great time with y'all today. Thank you. I know it took us a long time to get it together, but it's been a great day, and I'm glad that we got it done. For all of you that are still with us, 72, just keep telling people about my channel. Keep telling people that we're still taking patients in the North Central North Carolina area. Emmy needs to get filled up. The only way, to be honest with you, the only way our care spreads is if our care grows. So keep filling us up, and I'll just keep making content, as the Lord leads me. So.
Okay.
Thank you.
All right. Well, thank you for coming
All right,
on.
y'all.
Seriously, it was fun.